Coronavirus vaccines for children under the age of 5 could soon be available in the United States, plus the rise and fall of the Omicron variant. Hello, I'm Mike Walters, sitting in for Anna Naidu, and this is The Heat. The Omicron subvariant BA.2 is more contagious, but those vaccinated are less likely to spread it. That's according to a new study in Denmark. Here in the United States, the daily death toll from COVID-19 rose to an average of more than 2,400 over the previous week. That's up 39% over the past 2 weeks, the highest level in about a year, according to Johns Hopkins University. But some parts of the country are seeing encouraging signs, with cases and hospitalizations declining. And then there's this. Pfizer is seeking emergency authorization from the U.S. Food and Drug Administration for the first coronavirus vaccine for children under the age of 5. There's a lot to talk about. Let's get straight to our panel. Chris Smith is a consulting virologist at the University of Cambridge and co-presenter of the Naked Scientist podcast. Gavin McGregor-Skinner is a senior director of the Global Biorisk Advisory Council and an infectious disease expert. Also with us is Wilmot James. He's a former member of the South African Parliament and Shadow Health Minister. He's currently a senior research scholar at Columbia University's Institute for Social and Economic Research and Policy. And William Hazeltine is the chair and president of Access Health International and author of Variants, the Shape-Shifting Challenge of COVID-19. Bill, let's start with you. I want to get to Omicron and this subvariant that everybody seems to be talking about, but let's talk first about this news from Pfizer, the possibility that young kids 5 and younger could be getting shots perhaps as early as the end of this month. How big a deal is this?
Well, it's a big deal, especially for parents of children under the age of 5. They've been very worried. They've been worried that they will infect their children. They're worried that the older children going to school will come back and infect them. There's a much smaller risk that they will get ill than the adults, but there's some risk. And I think many parents would like to ameliorate that risk. And so this is very welcome news.
And it'll be a 2-dose regimen. Let's turn to Omicron. Globally, the original BA.1 subvariant accounting for about 98% of the cases. But now the close cousin, BA.2, quickly becoming the dominant strain in Denmark. Excuse me. The former head of the Food and Drug Administration, Scott Gottlieb, is talking about the danger posed by the subvariant. Let's listen to what he had to say.
I don't think it really changes the narrative. It maybe perhaps extends the tail on the decline that we're seeing across the country. There's some critical questions. Is it more contagious? It appears to be more contagious. Data out of Denmark from the Serum Institute suggests that it's about 1.5 times more contagious than the strain of Omicron that has made it around the U.S. Does it evade the immunity that we've acquired from Omicron infection or the vaccines? Most of the evidence so far, and it's preliminary, suggests it doesn't. In fact, there's data out of the U.K. that suggests that a fully boosted person may be more protected against this new variant than they were against the original strain of Omicron. And then the final question is it more virulent? Is it more dangerous? And so far, based on what we've seen out of Denmark and the UK, which are collecting very good data on this, it doesn't appear to be a more virulent strain.
In fact, a study out of Denmark shows that the BA.2 is 33% more infectious than the original strain. You've helped us walk us through Delta and Omicron. Walk us through this new subvariant. What are the features that you see?
Well, the first thing is it's pretty different. People say it's related. It's as different from BA.1 as Alpha is from Delta. There are a lot of changes. So there's unknowns. Secondly, in terms of its relative infectivity, transmissibility, the numbers actually, I looked just today at the Danish numbers. Within a household, it varies from 2 to 3-fold more transmissible. So that's significantly more transmissible. When you look at great detail at the changes in those regions that matter for vaccination, there are very substantial changes. There are a lot of changes in a region called the N-terminal domain. There are plenty of changes in the receptor binding domain between the two. And it shares a lot of properties, but not all the properties. It's a real mystery to where this came from and why BA.1, 2, and 3 came out at the same time. So I think we just have to wait. I'm not particularly alarmed that it's much more serious than the BA.1 variant, but we just have to see. It is displacing BA1, where BA1 and 2 are in the same population.
Not particularly concerned about it, Gavin. What's your take on BA2? Because, when we look at BA1, we saw cases just rocketing, and it was similar in other countries, United Kingdom, South Africa, of course, and then you saw this steady drop as well. So what can we see here? What are you anticipating?
Yeah, I know, Mike, you mentioned that this might be a cousin. I think all of us have been dealing with all the variants now since 2020, but Omicron is really starting to become representative of a family of COVID variants. Now, remember, Omicron suddenly appeared in November 2021, only a few months ago. And I know, Mike, you mentioned this was a cousin. It's definitely not a son or a daughter. We're seeing it more like brothers and sisters. And so as we see that, and we mentioned about the mutations, what was so significant about Omicron back in November 21 was the number of mutations compared to Delta. Now, the BA2 has about 32 of the same mutations as BA1. But as was mentioned, there are 28 mutations in BA2 that are different. And right now, we just don't know what they mean, but they're in that area of the virus that we're concerned about: transmissibility, severity of disease. So does BA2 now become more a virus that through these 28 mutations that can easily dodge or evade the immune system? But the other thing that I'm really worried about, Mike, is the speed of movement again of this virus. So we've seen BA2 infections identified and increasing in South Africa, Denmark, India, Nepal, the Philippines, also the United Kingdom. We've now seen it in here in the US states, especially California, New Mexico, Texas, and Washington. So in a few weeks, for the discovery of BA2, this variant has now moved around the world. Of course, it's moving mainly through passengers on planes, but it's moving so quickly. And again, we've also now seen BA3, another variant, which we don't know very little about, but it's now appeared in a lab in Belgium. So the speed of movement, the need for continuous and constant genetic sequencing, which we know is so limited in so many countries. So not all these countries can do all the tests that these other countries are doing. But again, how do we determine how these new mutations might affect human health? And that's what the studies are doing right now.
You mentioned this family, BA1, BA2, BA3, and you talked about your concerns. My concern is, BA83. How long? I mean, this thing just keeps mutating. I mean, talk to us about somebody like, I'm not nearly as knowledgeable as you are, but to me, it just seems like it's a never-ending trek. I mean, what can we expect?
Well, that's a really great question. Again, I'll go back. I mentioned last year I thought Delta was going to be the end of the pandemic, and we're going to go back to the way we lived our lives previously. I really thought that, but it wasn't until Omicron was found in November 2021. Remember, these are RNA viruses. They mutate all the time. But what's really interesting, this is like influenza, the flu mutates a lot. But what's very interesting about the SARS-CoV-2 virus that causes the COVID-19 disease, this virus, when it mutates, we're seeing, again, some of these mutations, like the BA1, now the BA2, actually spread and become a stable virus, a virus that overtakes another virus. Like BA1 pushed Delta away. It appears that BA2 was pushing BA1 away. And I know you mentioned BA83. I'm not thinking like that at the moment. What I'm thinking about is that we have so much natural immunity. And what I mean by that is so many people are being infected by BA1 at the moment. That's giving them immunity to more infection or severity of disease. But also our vaccine rates, the number of people that are vaccinated are very high now. So again, there's so many people within our towns, our cities, our neighborhoods that have immunity to the virus. Hopefully that will keep them out of hospitals. It'll decrease the death rates. And hopefully it'll decrease the chances of getting infected, so we see more mutations or more variants occur. Because the virus will only mutate and generate another variant if it gets a chance to infect more people.
Chris, the World Health Organization recently warned that conditions remain ideal for more coronavirus variants to emerge. So it's dangerous to assume that we're anywhere near the end game. Can you talk to us about that, and also the impact of vaccines being made available now for the first time there in England for youngsters 5 to 11? That's happening this week.
The first point I'd like to make is that actually, although people say it's alarming when we see these variants, I'm actually quite reassured that we're detecting them, because that shows our system works, and we've got extremely high resolution tracking going on in many countries around the world, so we can detect when these things pop up and then we can follow them. And the really reassuring trend emerging around these Omicron family variants is that they're not translating into severe clinical disease, because that's the marker we should be looking at. Cases are one thing, consequences are what matter. And it really is important that we focus on what extent is there a translation between a case and a consequence. About a year ago, here in the UK, we were seeing eye-watering numbers of people losing their lives every day, 1,500 people losing their lives every day in a relatively small country. And those were big numbers. The game is a completely different one now. We've got a very high vaccination uptake rate. In some sectors of society, that uptake rate is 96%. We've got very high rates of reinfection of people who've already had the infection with this Omicron variant. And this is almost certainly conspiring to endow people with very high levels of herd immunity. So what we're now seeing is that when the virus does come to visit a person, then actually they don't become severely unwell, because they've got that foundation of immunity which is protecting them. So we are into an era now which we would be with, for instance, influenza, and which we are with other coronaviruses, and which we are with other coronaviruses that were pandemics in the past. So that gives me reassurance and confidence that we are seeing the beginning of the end of this thing. I really think we are. In respect of younger people, of course, are at really low risk from coronavirus infection. There are, though, some people who do become severely unwell, but largely we know who they are. They're people with pre-existing health conditions, underlying issues that mean that if they catch anything, it can be a big problem for them. The vaccines work. They work very, very well at preventing people from having severe disease. And the physiology of a young person is almost identical to the physiology of an older person, and therefore really it's no great step to say let's give these vaccines to people who need them if they're younger, because they will genuinely prevent those people from becoming severely unwell.
Wilmot, I want to give you a chance to kind of jump into the conversation, maybe piggyback off what Chris said. He is a sense of optimism there, kind of the trade-off, more infections, less consequences. Is that how you see it as well?
Well, the work that I do focuses largely on Africa, and as you know, Africa's been lagging when it comes to vaccinations. I mean, the exceptions, Morocco is doing quite well, Tunisia is doing well, Zimbabwe and South Africa less so. I mean, South Africa is looking at 40% vaccination rate. So the average vaccination rate in Africa is extremely low. Nigeria is sitting between 3 and 4%. And that means that in order to contain the pandemic, there has to be a resort to an aggressive use of social interventions, public health measures, in order to make sure that you contain at least the current wave that's coming about. But that's highly disruptive of the economy, highly disruptive of travel. Africa depends on tourism in terms of revenues. It's highly disruptive of schooling. So the fact is that what has to be done is ramp up both the vaccination rates, and we know it's partly a supply problem in some cases. Otherwise, it's a question of further uptake beyond the plateau that you reach in a country through the initial vaccination stages. So there's a lot of work to be done. Aggressive rollout of vaccinations, aggressive use of social measures without strangling societies. And then, of course, we are also facing in many countries the problem of vaccine take-up once you've reached the plateau and having to deal with vaccine hesitancy. So there are many challenges. I think that there's a sense in which, given the fact that Omicron and its variants seem to be less pathogenic, that we're heading towards some kind of level of endemicity. But, you know, you can never be sure. Our information is not perfect, and we can't lower our guard.
Yeah, Wilmot, it's a good point, because the head of the WHO said that the unequal distribution of vaccines is the biggest failure of 2021. He went on to say it's a killer of people and jobs. It's still such a big problem on the continent, as you point out. And, Chris makes the point, maybe, more infections, less consequences. But that's the case if you do have some jabs, maybe the consequences aren't that bad. But for folks who are unvaccinated, it can still be very, very scary.
Yes, it is very scary. And especially on the African continent, where you don't have the kinds of level of political and social stability that you have elsewhere. I mean, there are 15 countries associated with some level of civil unrest and war, and so you have many countries where you don't have the vaccination platforms that's required. So that's a particular problem. And the fact is that the world will be flooded with vaccines pretty soon. It's heading towards that stage. But Africa's been the end of the line. And so it's really important to focus on aggressive rollouts and trying to fix what can be fixed in terms of upping supplies and then being able to use the vaccination platforms to get sufficient rollout. We've got a project underway in Zimbabwe, in South Africa, that will start in February, where we want to make sure that we have enough information from people who've been vaccinated to understand who influenced them, how to lower the barriers of access. Often many families will turn up after a great deal of effort, only to discover that there's an age grading that's used for vaccinations. So we have to lower the barriers of access, and we have to make sure that we target the right influencers in campaigns in order to increase vaccine uptake. So all of those things need to happen. The message is we can't lower our guard. We have to do better than what we're doing presently, and there's opportunity to do so. So I'm not pessimistic, but it does require effort, energy, and commitment.
Effort, energy, and commitment. Bill, also according to the WHO, about 23 million children around the world missed out on essential vaccinations in 2020. That's the highest number since 2009. And partial data suggesting immunization coverage remains below pre-pandemic years in 2021. I know we're talking about getting the shots for COVID, but how concerning is this other aspect of the story?
Well, that's very concerning. One of the pillars of modern public health and global health is childhood vaccinations. It's one of the things that's really been working well. Vaccine supply, vaccine distribution, even to the most remote parts of countries. It's been very encouraging, and this is discouraging news. I hope that we'll be able to get back on track. I'd like to take a step back and say, what have we learned from Omicron? We've learned some really surprising lessons. One, the virus is nowhere near the end of changes. It can change a lot more than we anticipated, and I don't think we're anywhere near the end of the changes. What those will be, whether for better or for worse, we don't know. But we also know something else that's a little bit more sobering, and that is we know we're unprepared to control it. Omicron is uncontrolled. It controlled itself if it's going to control. Nothing that we're doing. Our vaccines may be reducing disease, but they're surely not reducing infections, at least if they are. It's very hard to tell from the astronomical numbers of people who are getting infected. If there should be a variant which combines the transmissibility of the Omicron with the lethality of SARS-1, 4% of young people, 45% of older people, we're in deep trouble, and we're not prepared for that. I think we have to take a really hard look at how we are preparing ourselves for what could come. It doesn't mean it will come. What it does mean, though, is in any situation, you have to prepare for downsides as well as upsides. And Omicron has exposed glaring weaknesses in our ability to control infection. People are focused on the disease this has caused, and fortunately, it has caused less disease than we thought it would. But that doesn't mean the next one will. And what we know is that we are still unprepared in Western countries, not only in Africa and other countries. We are just not prepared to control it. And that, to me, is a fundamental lesson. Our vaccines don't stop infection. And if a new virus comes along that breaks through whatever it is that's protecting us from disease, which we still don't know exactly what it is, we could be in big trouble.
Yeah, that's a scary thought. Gavin, you know, he's talking about these glaring weaknesses, and yet you have a lot of governors in the U.S. who are just kind of so over this. They're saying we need to kind of just treat it as endemic, get on with our lives, that sort of thing, basically learn to live with it. And we're actually hearing from the top infectious disease expert in the United States, Dr. Anthony Fauci, also talking about this kind of new normalcy. Let's listen to what he had to say.
Where we want to be is that sufficient control, and control we mean not eradication like we did with smallpox, that's unreasonable, not necessarily elimination like we've done with polio and with measles by mass vaccination campaigns, but a level of control that does not disrupt us in society, does not dominate our lives, does not prevent us to do the things that we generally do under normal existence. That would be a level of infection, but more importantly, concentrating on the severity of disease, hospitalizations, and deaths that fall within the category of what we generally accept. We don't like it, but we accept it with other respiratory viruses.
So, Gavin, is that the world we're going to be living in?
I think it's really important, Mike, that we start focusing on how to live with COVID-19. How to live with the SARS-CoV-2 virus. I travel every week for the work that I do. And what's surprising me right now as I travel throughout the many states here in the US, and I do this every week, is the number of people that are now coming back into the workplace still with symptoms, still sick, because they don't have enough sick days. They can't take sort of disability time off. There's no available time for them to stay home and look after themselves, or even look after family members that might be sick. So I was in a hotel the other day where I was giving some training, and I said to the staff, "Why are you wearing 2 masks?" "Oh, that's because we tested positive this morning for COVID-19, but we're not really that bad, so we can still work." So you're positive, you've got some symptoms, but they're not severe enough to put you in bed or put you in hospital, but you can still work. And they were wearing 2 masks. Where did that come from? I don't know where that came from, because that's not real. It's not what's needed. So it's really important that we start looking at how to live with the virus. Like Will said, with the Omicron variant, as it still circulates, will still change, and how we manage to keep essential services going. The other thing that I'm seeing a lot, Mike, as I travel around the US is these vaccine preventable disease schedules for kids are so off at the moment. They're so over the last 2 years, because people have been in lockdown, haven't been able to leave their house, haven't been able to get go to schools or get medical services. So many of the young kids under the age of 5 just haven't had the regular, normal vaccine preventable vaccinations that they would normally get before the age of 5. And I do a lot of work overseas in island nations in the Pacific, the Caribbean, Southeast Asia, and I'm hearing reports there that their vaccine schedules for young kids are off as well. And we're now hearing some measles outbreaks. And again, I've seen, unfortunately, throughout my career, I've seen tetanus in kids in countries that have had war, conflict, natural disasters, man-made disasters. And I'm now hearing reports of tetanus in kids. And that's the worst disease you could ever want to see in a child.
Oh, geez. Well, Chris, let me talk to you, because you kind of sounded an optimistic note. We're hearing words like normalcy and living with it. Well, the one word we really want to hear is decline, but where do you see us actually turning the corner on this?
Well, I think we have to accept that this is an endemic infection. There's no evidence that this virus is going to go away. We are pretty much in agreement that we can't get rid of it, we can't eradicate it. There are various reasons for that, but one of them is that it's everywhere, and there is so many people who could have it again despite vaccination or despite prior infection, and it's a moving target, that we have resigned ourselves to the fact that it will become endemic, or if it isn't already endemic. And so therefore we have to make a plan for its impact on us. But actually taking a look at history can be informative here, because it's not the first time that we've confronted pandemics. And in 1918, we had the Spanish flu pandemic. And in the 1890s, there was another pandemic that was probably misnamed the Russian flu. And looking at this through the lens of forensic molecular biology, we can probably say that wasn't a flu at all. It was probably a coronavirus infection. And there's quite good evidence that that 1890 Russian flu was in fact bovine coronavirus jumping the species barrier in animal markets, getting into people and then causing a huge pandemic that actually claimed the lives of many people. Members of Queen Victoria's royal household died in that pandemic. Where did that virus go? Well, the answer is it didn't go anywhere. It's still with us today. It's called OC43, and it causes maybe 5% of the colds and coughs that circulate in the average winter time. So, in other words, we went from a pandemic situation to a situation where the virus became endemic, the human population became able to tolerate it, catch it serial times across a lifetime, and therefore not succumb to it when you're elderly. Because one of the big problems we have at the moment is there are people who are older, more vulnerable, health problems, meeting this new virus for the first time in their life, and their immune system's not prepared for it. If you've been catching something for your entire life, you build a baseline foundation of immunity, which means that you're more likely to be able to shrug these things off. So I think what we're doing is transitioning into that situation where pretty much everyone has met this virus, or they've fooled their immune system into thinking they've met the virus by having serial vaccinations. So eventually when you do meet it, and most people agree that we're all going to have our day with it at some point, then actually we have a trivial infection, not a serious one.
Yeah. Wilmot, let's get back to some of the things that you and I were talking about earlier. According to the WHO, the last 40 days of 2021 reportedly saw more vaccine doses shipped to countries in need through the COVAX program than in the rest of the year combined. But that's just one issue. And as well, you know, there are still other challenges like underfunded healthcare systems in these countries. You know, it's the haves and the have-nots, countries doing very well, others struggling. How do we level that playing field?
Well, that's a huge challenge. There's some immediate things that can be done to strengthen vaccine rollouts, for example. In terms of building capable health care systems, that's a much longer term process. Most hospital systems in the developing world, I know in Africa certainly, can't cope with surges, and therefore it would place healthcare systems under stress, put healthcare workers under stress. That's a long-term process of building resilience in healthcare systems. So we have to strategically decide what can we do now to improve the quantum of vaccines going into Africa, for example, and then rolling it out and dealing with a vaccine hesitancy. That's an immediate challenge, how to strengthen the vaccination platforms, how to make sure, as mentioned before, the secondary impact on the routine immunization is being able to deal with that issue. Something can be done about that immediately. And then there's the medium-term questions around, for example, sovereign vaccine manufacturing in a variety of sites across the globe. That's something for the future. It's not really going to make an impact on this current pandemic. And then building resilient health systems, which is a long-term process of persuading governments, if they need persuasion now, that they should invest in their own healthcare systems, because the investment level in many parts of the developing world is quite low.
I think that's one thing the pandemic has certainly made very clear to everyone. Thank you, gentlemen. It's been a pleasure. And that's it for this edition of The Heat. I'm Mike Walter, Washington, D.C. Thanks so much for joining us.